Okay, so what I want to talk about is what do we mean by humanising care. So I'm going to take a few minutes just to share with you the reason why we think humanising care is so important and touch on some of the ideas about where it came from and why it is useful to us. We don't have to look too far to notice that something is missing in health and social care. And we know that patients and service users are telling us in different ways that they aren't always fully met as human persons in the places and contexts within which they receive care. And our project is really about trying to understand the things that make people feel human in care, and also how those things can sometimes be obscured or are even at risk of getting lost within the complex care services that we have. So what is this emphasis as being obscured? On the one hand, we've got increasing specialisation, and this is a really good thing because it's delivered gains in mortality and morbidity that we could never even imagine 50 years ago, and significant improvements in health and well-being for populations. But on the other hand, there's increasing evidence in a number of places, if we think about the image of health and social care in the media, and we've got particular type of research, qualitative research, of which we have many examples of the kinds of things that go wrong when the human dimensions of care become obscured, when there is an emphasis only on the technical and specialised aspects of care. Those specialised and technical aspects of care are extremely important and they have to be attended to, but they can inadvertently obscure or push out even inadvertently what it is to be human. And that's the area that we were really interested in this project, in these two sites, within a stroke rehabilitation setting and within a skin care and health outpatient setting. So we all want efficient and effective healthcare. It's absolutely necessary. And when we want an efficient and effective healthcare system, that means that there is, of course, an emphasis on economic aspects, management aspects, statistical aspects, outcome measurement aspects. But very unintentionally, if the emphasis is only there, this very important thing of the breadth and depth of being human is dropped out or can be left to one side. And so we wanted to keep a focus on that breadth and depth of being human. What did the breadth and depth of being human mean within a skin care outpatient setting and within a stroke rehabilitation setting? And what would it take to do justice to this very complex requirement about humanising care? So there's been a lot of discussion, talk, a lot of literature about person-centred care, humane care, holistic care, the 6 C's, and so on. And we wanted to offer something that was very distinctive, that could offer practical directions for care and specifically address dimensions of being human. And that's what we've been trying to do in this project, trying to understand how that might work and what kind of steps a group would need to take to do that sort of work. And we want to argue that by taking a focus on what it is to be human and thinking about the dimensions of being human and thinking about what that means within a health and social care context and within what matters to people within services, that this would act as a living foundation for ensuring dignity for people in care in ways that perhaps a top-down tick box or procedural approach might not be able to do. So that's what we were really trying to test out. So what does it mean to be human? And we started, our beginning place for this was to build the work from a particular philosophy, and that was a life world approach to care that could give us directions for practice and research. And the life world is how we experience the seamlessness of life as we live through life, in time, in space, in our bodies, in mood, and with others. So that was the foundation for us to develop this framework that would point to the directions for human dimensions of care. And we asked this question in developing the framework, and that was, what would make people feel more human in the places and contexts that they receive care? And through a process of reflection, using the life world as our basis, we were able to identify and name or articulate 8 dimensions. And these 8 dimensions are possibilities that occur along a spectrum. It's not a list of do's and don'ts. So dehumanization can occur when one or more of the humanizing dimensions becomes obscured. And what we're arguing is that this isn't a dualism or a split between humanizing or dehumanizing, but there can be a range along a spectrum of possibilities. So it's very different to an either-or approach. And one of the things that's very important here is that care is a very intangible thing and a very complex thing. And often what we know about good care becomes visible in its absence. So it's when it is missing that it becomes highly visible, and that's why the dehumanizing dimensions are also as important as the humanizing dimensions. And it's a way of thinking about care that gives us a handle on care, because it's intangible, in ways that we don't think other approaches have managed to do as successfully so far. And now we're trying to test out this approach to see if it is as good as we think it might be, have potential for. So it's not a list of do's and don'ts. It is rather a trying to re-emphasize values, and the 8 life world informed dimensions guide a consideration of the caring system. And we also see it as a sensitizing background to care, so that people working in human services have got a framework that helps them keep in touch with the human dimensions of care, keeps them in touch with the values that brought them into a caring role in the first place.